I'm Rick McGuire, the Executive Editor, CardioSource World News. I'm with Dr. Sandeep Das, and a Parmley Prize winner, Young Investigator Award. Can you first off, before we start talking about the subject matter of the interview, about the Parmley Prize, Young Investigator, who were your colleagues who were honored as your teachers, your mentors?
Really, it's clearly a shared award. My mentor is James DeLemus. He's just outstanding. I think probably many of your viewers will be familiar with him.
Right.
But he's a force in cardiology as a young investigator. It's been a pleasure to work with him. Also, the people at the NCDR Action Registry have been enormously helpful. Matt Rowe, Karen Alexander, the statistical support team, Anita Chen have all been wonderful. Eric Peterson.
I mean, when I first read your paper, which was, I think, in one of the December issues of JACC, I read everything beforehand because I actually work with JACC and do some stuff with them. And I remember reading your paper and it's like, this is really cool. Then you win the prizes. Oh, I got to talk to him. This is great.
Yeah, think how I felt. Yeah.
Yes, exactly. So tell me a little bit about the NCDR study that you conducted, because it really is an important, it gives us some important insights.
What we are very interested in is looking at how process of care and outcomes differ for the extremely obese versus normal weight or mildly obese. So obesity is ubiquitous in cardiovascular disease populations these days. Pretty much everybody that rolls in the door is more likely than not to be at least overweight. But one thing that I think is under-recognized within the global context of obesity is the segment of the population that is extremely obese with a BMI greater than 40 kilograms per meter squared. So this population, we have data from the Dallas Heart Study in Dallas County that shows that especially among African Americans and women, this is a segment of the population that's growing quite a bit faster than the overall rise in obesity. So I think that this is an underappreciated group because there's a lot of logistic complications related to them. There's issues with cath table weight limits. There's issues with dosing drugs. So there's questions with how processes of care may differ for this group, and then clearly outcomes. So there are large cohort data that suggests that there's what's called an obesity paradox, where the people that are obese, once they have disease, although they're more likely to get disease, but then once they have disease, they have better outcomes. And this has been seen in heart failure, in myocardial infarction, post-cardiac surgery, all sorts of different populations. And I think that the subgroup of extreme obesity needs to be sort of separated out from the sort of general garden variety obesity. I hate to cringe to say it a little bit, but this extreme obese phenotype I think is not nearly as benign. I think that there's a danger here that we get lulled into a false sense of security where we think, obesity is bad for you, but it's not that bad. And I think that there is a certain subgroup where perhaps it's particularly bad. So what we did is we looked at process of care and outcomes for this group that were extremely obese and compared them to the less obese and the normal weight. And what we found is that one thing that was very reassuring is for STEMI that process of care was quite similar. Across the board, everybody got state-of-the-art care. And that's really, that's actually really reassuring, honestly. That people didn't get treated differently because they rolled in the door and they weighed 100 pounds more than the person in the bed next to them. But we also saw an increased risk for mortality in that group, about a 50% relative risk increase in mortality, in hospital mortality. And that's very concerning. So really that points to one of two things. Either there's something inherently intrinsically bad about being very obese, or that there's other factors here that we're not fully capturing. And I think the real strength of registries like the NCDR Action Registry is that we can look at very large numbers of patients, and we are very good at describing what's going on out there in the world of cardiology. So, historically we've been limited to data from single centers, and if you wanted to do a study of extreme obesity, even at a large single center, you might have 100 extremely obese patients. And we had thousands. So I think that really is a kind of research that's not only facilitated by large registries, but really impossible without them.
So for a patient who is extremely obese, then the option is this is aggressive treatment time, no matter what. For risk reduction, this is aggressive time.
Absolutely. I think that all kinds of obesity are associated with increased incident cardiovascular disease. So whether that's mediated through risk factors like hypertension, diabetes, or through some intrinsic factors related to obesity that may be less well understood. So I think that obesity per se needs to be addressed and treated aggressively across the board. Now, extreme obesity, we do have tools. We have, fairly extreme responses to extreme obesity, things like bariatric surgery. And it's always, the decision making is always tough because although the rewards are the highest in aggressively treating these people with therapies like bariatric surgery, obviously the perioperative risks are the highest in these very, very obese people. And I think that data like this that came out of the NCDR show that help us inform the risk-benefit decision. It kind of help us decide whether whether it's worth it, or the risk of the surgery, not worth it in general, but worth the risk of the surgery to go to be more aggressive. And I think that my data didn't speak to that specific question, but I think that my general feeling is that it definitely, this is a population we need to be very aggressive about risk factor modification.